Thanks everyone for joining today, the Price Talks in a Pandemic series. I'm LaVonna Lewis, and my research really looks at issues of health equity and cultural competency in healthcare organizations. And I'm going to talk today about uncovering health disparities during the pandemic. And so it's going to involve a little bit of back to the future. So thank you for joining. And so I want to start with the basic definition of health disparities, looking at disparities as the differences in incidence and prevalence of health conditions and health status between groups based on these kind of categories: race and ethnicity, SES, sexual orientation, etc. I would draw your attention to the combination element, and here think about intersectionality. What happens when you have someone with a disability who also is poor and lives in a community that may not offer support for people with disabilities, and again, to just kind of think about that over the long term. As I said, we're going to involve a little bit of back to the future, and so this is as far back as we're going to go. Yes, that is 1890. Yes, we're talking about a report that was done in 1899 using 1890 data. The titles are appropriate given the time, and this is Du Bois's dissertation that really talked about health disparities between whites and Negroes in Philadelphia. And as you can see, as you look across the various categories, the majority of the differences are in the favor of the Anglo population. So again, we're talking about back to the future. We're on a discovery journey. And as you can see, again, disparities are not new. What may be new is our attention to the topic. And again, I'll talk more about that as we go forward. Healthcare disparities or health disparities are also costly. But before I get into the kind of this particular report, I just want you to look at that definition. Disparities denotes differences, whether they are unjust or not. Inequity denotes differences in health outcomes that are systematic, avoidable and unjust. And so when we talk about disparities, when we talk about issues of equity in health, this is why I prefer equity as opposed to disparity, because it really talks about things that we believe are systematic and could also be avoidable. This is an older report written in 2009, trying to quantify the economic cost of health disparities. And the research here basically asks the question, what happens when we look at the different priority populations here, African American, Asians, and Hispanics, and compare costs for healthcare to whites? And what you'll see is that here, that simple question said that if the health status of those minority populations or underrepresented populations was the same as the white population, we would have had roughly $230 billion that we could have used for perhaps other things in our healthcare system. And again, those other things are open to debate, but just the idea again of what could we have used that $230 billion for. Similarly, they expanded the research in that same study, and they began to ask, it's not just about direct medical costs. What about things like the cost of disability and the supports that are associated with dealing with disability, worker productivity, the cost of premature death, and the fact that, again, there is a social cost when people who may be in regular circumstances, high wage earners, are making valuable contributions to society, die early. And so as you can see, the estimates, again, of those costs for that 3-year period, again, 2003 to 2006, all adjusted to 2008 dollar figures, means that we would have had roughly, again, $1.2 trillion of extra additional resources that could have been deployed into other means. And again, in our current conversations, we're hearing the term $1 trillion quite a bit. But again, just to understand the fact that we're just talking about cost associated with dealing with difference across these, again, these kind of priority populations that we discuss so frequently in our healthcare. Again, as we're going back to the future, I want to introduce or reintroduce to some of the folks in the audience a seminal piece of work that was done by the government, the Institute of Medicine, entitled Unequal Treatment: Confronting Racial and that should be and ethnic disparities in healthcare. And again, I think it's important to acknowledge the fact that, as the authors found here, as they did the survey of the literature up to that point, again published in 2002, that they were able to demonstrate a consistency as related to disparities, something that wasn't every now and then, but something that persisted across a wide range of healthcare services and settings, disease categories, even when things like we consider protectors, our income, our education, healthcare, insurance, are controlled for. These disparities persisted. And so what else did the IOM, or the unequal treatment, tell us about disparities? Again, it said they are basically things that we should consider, that they exist. They are not the figment of anyone's imagination. They exist, and we should consider them unacceptable. They occur in context of persistent, again, this idea of not something that happens every now and then, but in multiple sectors of American life. So even though we're talking about health today, I know you've been listening to the policy series, and you see these disparities come up in multiple venues, whether it's education, homelessness. Again, they persist. Again, there are many sources that contribute to the disparities, whether we're talking about the system, the providers, the patients, and again, those folks who are making decisions about who's going to get what type of service, and again, paying for those services. This issue of bias, stereotype, prejudice also exists. Here in 2002, they were talking about these things may exist. Research that's been published subsequent to 2002 have demonstrated there is evidence of bias in some of the things that we're seeing as it relates to healthcare providers. And again, that last bullet talks about the fact that, again, there may be differences in terms of whether or not people of color are willing to accept treatment. There's a whole literature that just talks about issues of trust that people of color have with the medical system and research in general. But even with that, that does not explain all of the disparities that we see. So disparities, again, just think about the wide range of categories. Again, we're talking about people with insurance. A lot of folks make mention of the fact that coverage is the issue. If people just had access, everything would be more equitable. Here we see, even when those people have, or when we writ large have insurance, we still see disparities based on race for things like vaccines, surgeries, transplants, treatment for pain. What happens when someone needs a specialist? Are those referrals being made? There's been a lot of attention recently in terms of prenatal and maternal health care. We've had high profile situations where women of color, particularly Black women, which are known to have, Black women with advanced degrees have worse outcomes than white women that drop out of high school. And again, as it relates to birth outcomes, so there's a lot of attention in terms of low birth weight babies and again, maternal health, particularly for Black women. And then end of life care. And I think it's important that those two are together side by side, because it shows that whether or not we're talking about the beginning of life or the end of life, there's evidence that disparities persist across the lifespan. The last thing I want to talk about as it relates to kind of the Institute of Medicine, well, next to the last, is just really to understand that it came out also in the context of a push toward quality in our healthcare system. And so this idea that why don't we talk about disparities and quality at the same time? And for those of you who may not spend a lot of time in the healthcare space, there were certain recommendations for a 21st century healthcare system. It should be safe, it should be effective, it should be personalized or patient-centered, it should be timely, it should be efficient. The sixth bullet that was also part of the system was equity. And so what you'll see if you look at the literature since the release of the Quality Chasm Report and the Unequal Treatment Report is that you'll see while we've made some gains in most of these areas, again, we still see greater medical errors with people of color, less likely to use evidence-based care, making sure people have informed consent, having to wait for procedures, again, just general poor communication, having to wait more to see the provider. What's not here is, again, equity. Even though it's part of the argument, we see that gains have been made in most of these areas, but still equity and the concern with, again, people getting what they need in the healthcare system lags behind. And finally, this is for my policy, as again, we're at Price School of Public Policy. And so there were some recommendations that were made if we wanted to move the needle as it relates to dealing with disparities. And the first one, just to increase awareness of existence of disparities. In 2020, we are being reminded that disparities exist. Again, they're not new, but for many people, they are on the radar screen for the first time, in part because of COVID-19. We also were encouraged to address the systems of care. Again, what's happening when people navigate healthcare institutions. And again, one could ask the question, if COVID-19 is currently overwhelming the system and equity were the problem before COVID-19, again, what's the capacity of the system to handle this additional stress? Again, provider education, patient education, and again, kind of the research. And one of the things I want to make clear that really needs to be understood is the importance of the accessibility and the availability of the data. And I'll talk more about that in a moment, but to understand, in order for us to really begin to dive deeper into what some of these things mean, we have to be able to collect meaningful data. And so just going from the past to the present, this was yesterday. And again, I had to have a cutoff date or cutoff in terms of when I was bringing in new information. And these are the numbers for today. As you can see, heart disease and cancer, stroke are not new, again, to the top leading causes of diseases in this country. Clearly, the new elephant in the room is COVID-19. And again, the variation in terms of projected deaths depends on whose model you happen to be taking a look at. But again, I think the expectations are alarming, whether you take the low end estimates or the higher end estimates. So again, the CDC, government resource, which is designed to, again, collect the data for us. Again, as of yesterday, we can see that 26 states report more than 10,000 cases of COVID-19. And again, while we sometimes talk about the coast, I think we have to recognize that this is a virus. This is a situation that we're all impacted one way or another. The numbers may vary, but the virus is present across the country. It's present globally. And so we have to think about, again, the consequences of that. Here we're talking about taking that kind of broader conversation and kind of going a little bit deeper into the data. And again, this is, as you can see, that the highest percent of the cases have been, again, are noted for the Anglo population, the white population. But again, we can also see the other categories, Black, Asian, etc. But what I want to draw your attention to is the fact that, look, even though this is data from over 1 million individuals, less than half of those individuals provide race data. So when we're talking about, again, COVID-19, recognizing that we're consistently reporting age, we're consistently reporting gender, we're not consistently reporting race. And again, there's a big push for that. But again, recognize that that's part of what we have to understand, that there are certain benefits to what we don't see. And so what do I mean by what we don't see? If we don't report on race consistently, we don't see the privilege gap in the data. And so what do I mean by the privilege gap? When we say stay at home, that's not an option for essential workers. It also assumes that I have a home. When we say wash our hands, we're assuming again that I have a place to wash my hands. And if I do have a place, there's no guarantee that I have running water, because there are still places in the United States where people don't have running water on a regular basis. Wear a mask. Wearing a mask can mean very, very different things based on your profile. We've seen evidence that in policing of wearing a mask, if you happen to be Black or brown, you're more likely to be ticketed for not wearing a mask. You're also likely to be a victim or run into situations where if you don't wear a mask, in some situations you will be harassed. If you do wear a mask, you will be asked to leave the premises. So this idea of privilege, we assume that wearing the mask for everyone means the same thing, and there's evidence that it doesn't. We need to be very intentional about the impact of race, place, and class. Again, there's evidence that there's a disproportionate effect on people of color, disproportionate effect on certain communities, which again have higher levels or higher proportion of people of color as it relates to the geography and class. There's evidence that, again, being low income wage earner puts you at greater risks for some exposure to the negative effects, again, of these disparities and COVID-19 in particular. And then that last bullet, disasters, whether they are man-made or natural, always expose the inequity. So again, inequities are not new. What is new is the spotlight that's currently being placed on those inequities. The real question is, what happens now that these things are getting the spotlight? Will we go back? I mean, will it be the status quo, or will there be significant changes in terms of, again, trying to more systematically address issues of inequity in our healthcare system and other systems as well? They say a picture's worth 1,000 words, and as I want to end my presentation with two pictures that I felt were particularly timely. This picture ended up in my on my Facebook page, and it makes a very powerful point. It makes the point that privilege can allow you to see from a different perspective. Privilege allows you to live a longer life. There's evidence that, again, that the more money you make, the longer you stay in school, the more likely you are to live longer. It adds longer years of your life. But it also says that I don't have to see what's going on beneath me if I don't want to. The social determinants of health has demonstrated consistently that the higher you move up on the social ladder, the greater your circumstances, both the quality and longevity of life. We are being bombarded with this message day in and day out. The question is, again, other than applause and a hand clap, what's really going to happen as we kind of think about, again, trying to put people in meat packing spaces, or delivering our food, or pulling the food from the ground? I mean, what's our obligation to deal with the disparities that may result long term as we continue to expose those essential workers to the virus? Again, there's a lot made of clinicians, and clinicians should be celebrated. Who's not celebrated as much, who's also there, are the folks that are cleaning up the hospital rooms and who are throwing away all of the biohazard. So let's recognize where we are, and again, our commitment. And then this last one, which I think is important for us all to understand, is that it's bigger than the individual. We have to acknowledge that there are multiple forces at work that need to be interrogated if we're really going to address health disparities in kind of a significant way. We need to understand that that there's a difference between public and private health care. We need to understand that policy can change the rules of the game overnight. We need to understand that the media influences how we think about people, and on and on. And someone needs to be exploring each of these in greater detail. I'm delighted to be part of a school and a university that takes these things seriously. That's the end of my presentation, and I would be happy to answer any questions that you might have.
Hi, yes, we have a couple of questions coming in, LaVonna.
Okay.
First question, the federal government is currently sending COVID treatment to states for distribution to hospitals. How should the allocation of COVID treatments take disparities and inequities into the account?
So I think the first thing is to consider is that, and I don't know, again, it's like we're at a point now where we don't know what's true or what's false. But what I do know, what I read was that at one time we were sending those treatments to places that didn't have a greater need. So that's a missed opportunity for me. In terms of how do you distribute, I think you distribute to the areas of greater need, recognizing that at some point you may have additional resources, but it should be where the need is, where that felt need is at the present, that gets the greatest allocation of resources, because again, the need for recovery, the need for help is greatest there.
Okay. Next question is, why do you think that African American women with degrees still face healthcare inequity?
So the research speaks to issues, quite frankly, of racism and the stress of racism. Research has been done that shows that the birth outcomes for foreign-born African women, people who come here as immigrants, are better than for native-born African-American women. And part of the argument is that folks coming from outside of the US don't have the burden of the history of racism in this country. And so the cortisol and the other biological impacts of that are not present. And so again, the birth outcomes have been seen as more promising there.
Okay. The next question is, as you mentioned, it's important to be conscientious of language and making assumptions when communicating policies, like wearing masks, washing your hands, etc. What is your recommendation for being more inclusive and mindful with language while still quickly and effectively communicating to a diverse county like LA?
So, I mean, I think it starts with, being open to interrogating the people. Interrogating is not the right word, but to basically ask the question, right? It's like, what are you most concerned about? How can we help you the most? Instead of assuming that we know what people need, then we've got to be willing to say, look, these are the things that people have usually recommended. I mean, are any of these particularly difficult for you? How can I help you with some of these things? So I think I would say that it begins with the basic sense of empathy and respect for people to understand that what we're asking people to do. I mean, something as simple as our transition to online education. I mean, unmasked disparities for some people, because again, some of our kids don't have the kind of internet access and kind of study space that some of our other students have. And so it's that awareness that I need to find out, from an empathetic lens, how can I help? How would I feel if people were asking me to do things that I wasn't able to do? It would be nice if someone just asked me, are you having any difficulty making ends meet or responding to some of these issues, and what can we do to help? Because again, something as simple, again, we've seen that people have been putting up hand sanitizer stations in communities, and that's saying, look, we recognize that this is not uniformly available, so I'm going to make it available. Rather than assuming that people can buy their own masks, then maybe part of what I have to do is be committed to buy them for them. I mean, there's a lot of conversation going on about how do we take people off the streets. I mean, that's a big part of it. It's hard to, stay in place when you don't have a place.
Right. You have referred to literature several times. What are major gaps where research is needed but has not been undertaken?
So I think for me, the really big issues are this idea of getting to understand in greater detail the issues of stress, the issues of racism, the issue of trauma, all those things which may not show up officially in the healthcare arena, but maybe driving everything that's happening in a given community. I mean, my ability to respond to situations is dependent upon my networks, it's dependent upon my resources. And so long as those aren't part of the conversation, it's going to be very difficult. I think we have to be willing to be tested in terms of our own biases, to understand that just something as simple as how we ask a question can send a very different message than we're intending it to. So I think that we have to understand, it really is to understand, yes, the biology, to understand how our systems are organized and make it easy for some people to navigate our systems and very, very difficult for others to navigate our system. If you go back to that last slide that I had, I think that there are open research topics in all of those areas. It's just recognizing that it's bigger than any one research team, but I think with the kind of a collective agenda, it can be done. I think our attention to the social determinants of health is evidence that it's bigger than the clinical interaction, and so I think we're beginning to explore and interrogate that more.
Okay. Next question is, knowing that people of color are experiencing greater risk with regards to exposure to COVID-19, do you think we will see any legal battles against healthcare institutions / hospitals for lack of addressing disparities which may be seen as leading to systematic exposure to the virus?
That's an interesting question. We live in a very litigious society, so one could argue that people are always looking for a reason to take people to court. And again, I don't know how that's going to end up. But I do think that there's evidence that, for example, in the medical era literature, When people admitted that they made a mistake, the families were much more forgiving. I think we should kind of think along those lines as well, to recognize that we've got to be more mindful of who's in and who's out as it relates to healthcare, and to recognize this is an opportunity to change the status quo. Someone said that you should always be willing to take advantage of a good crisis. I don't know what a good crisis is, but I do know that there's a chance for us to reimagine what health and healthcare looks like in this country. And I would hate for us to lose the opportunity and just kind of push it down the road. Again, I started in 1890. We're now in 2020, and the issues persist.
Next question is, do you believe President Trump's evident unconscious racial biases have affected the COVID-19 public health response directly or indirectly with any significance?
Yes.
Do you think this health emergency will be a catalyst for changed federal, state, and local policy regarding equity in healthcare and in other areas?
So that is my hope. I am 60 years old. I don't remember a lot of windows of opportunity in my lifetime. And for those in the policy that are not in the policy arena, when a problem, a solution, and the political will all come together, something radical can happen. This is one of those radical moments. I hope that we are up to the challenge. Again, that's my hope. But again, I also know that we call it the status quo for a reason.
Next question, how are health disparities affecting education now and potentially in a future world with continuing remote learning?
So we think about a child being ready to learn. I'm not ready to learn if I need glasses and I don't have them. I'm not ready to learn if I need hearing aid and I don't have them. I'm not ready to learn if I need accommodations and I'm not getting them. And so I think the fact that we're putting kids in environments that don't have the technology capacity, that don't have maybe that quiet space, don't have perhaps regular diets, that has consequences. And again, I'm hopeful that we think about this sooner rather than later. And so we're not trying to kind of put a patch on a gaping wound, and that we don't think that it's okay to leave people behind, that we hold one another accountable for kind of our collective future and not just the future of a few.
Okay. I'll get through one more question. If homelessness has not been addressed effectively, even when resources are allocated at the state level, how behind and how hopeful are we in addressing public health and COVID-19 related health issues for this group of the population?
I think again, that is the reality. I mean, right? I mean, we have to recognize it's going to be a heavy lift to bring those who have been to bring those who have been the most disadvantaged into a system of care that's not designed with them in mind, quite frankly. We are not designed for literally millions of people to be at risk all at the same time and not having vaccines or treatment for dealing with everybody at the same time. I say that.
Oh, no, go ahead.
No, I say that to recognize, again, it's like we can't say we're not going to do our best because it's too hard. We're behind. Unfortunately, that means that, people are going to suffer because of our lack of preparedness. But again, that doesn't mean that we should be okay with just being mediocre and just doing the bare minimum as opposed to having all hands on deck, doing the most that we can to impact lives for positive outcomes.
And I'll end with one last question. For individuals who are in the medical field or who will soon enter the medical field as doctors, nurses, etc., what can they do to help address these inequities and work towards systematic change?
So I think it's important that the clinicians recognize the power of their voice in terms of getting us all to think more intentionally about what happens outside of the healthcare system. A person that we're calling non-compliant because they won't follow our dietary recommendations may just not be following them because what you're asking me to purchase isn't available in my neighborhood. Forcing people to ask those questions about what's happening that we don't see when we see the patient, I think is critical. And so I think the clinician's role in that is important because, again, you're asking the questions. You have those teachable moments when someone's right in your face, either as a patient or a peer, to basically ask them, again, it's like, what do you know about the people that we see? What do you know about their circumstances? And again, what are we doing to make a difference? I mean, some healthcare systems are providing food for their diabetics because they recognize that what I want them to eat isn't available. It takes that type of effort, not just talk, but also walk.
Thank you so much, LaVonna, and thank you all for joining us today for Price Talks. We have another session tomorrow, and we hope you can join us then. Thank you so much.
Take care.